Hi, Brenda. Brenda, can you hear me? Hello? Okay. Barbara, can you hear me okay?
Yes, I can hear you perfect. I'm going to turn my video off for a minute before the meeting begins.
That's okay. I just wanted to make sure you people can hear, so that's brilliant.
Yes,
Yep.
hear you perfect. Thank you.
Okay, thank you. Thanks, Paul. It's all up and running. Angela?
Hi, Lawrence. Yeah, I'm here.
I might have some problems with you sharing the screen, so do you want to send your PowerPoint until I can work out how to do this?
Ah, okay.
Send me your PowerPoint by email. I'm trying to get.
Lawrence, if you make Angela co-host.
I'm not the host. That's the problem. Paul is, and I can't get Paul. Oh, I can't do that. Oh.
Okay, so you need me to send you.
No, hold on. I can't actually.
Sorry, can you or can't you?
Yeah, I can't make you.
You can't. Okay, I'm sending it to you. So I'm sending it to you now, Lawrence. Is that okay?
Yeah.
All right.
Lawrence, is everyone here that's going to be here, or are we waiting on some?
No, we're waiting on people. So.
Okay, because I can give you an alternative number if you want.
No, too many people.
Oh gosh, there is some feedback.
Host, you see?
Okay, Lawrence, it's well, it should be on its way to you.
Omicron is especially dangerous for underage groups.
Afternoon.
Hi. 2 vaccine doses. Those who don't get boosters are over twice as likely to end up in hospital. So get boosted now. Appointments or walk-ins are still available near you for all vaccine doses. Go to lidirect.gov.uk/get-boosted.
Just if everyone at the minute could just mute yourselves, please, so we get sorted out.
Forgettable. And here's something you won't want to forget. At Tiles Plus, Gold Marble Effect 60x60 porcelain floor tile was
Bernie's TV as well.
My half price.
Who is it?
Tiles Plus is now open until 8 p.m. on Thursday. So
Bernie.
Because
Bernie, could you just mute yourself or turn off your TV or radio? Sorry, Angela, I'm waiting for this just to come through.
Oh, it hasn't arrived yet.
Well, it has. It's university scanning it. So we'll just give everybody a couple of minutes. It's just not quite 2 o'clock yet.
I'm doing a training today, so you can be quiet. All right. Now has to do this work today for work.
Training with Charlie?
Not training with Charlie, no, training with work. Pardon me. It's a very good boy.
It's 3 now, Angela.
So you can, if you're going to show the slides, then I say next slide or something. Is that you're going to handle it? Okay. I mean, I've got it open on my computer as well. So.
Because I'm not host, I can't give you. I'm just. So you can see your PowerPoint now, Angela?
Yeah. Okay.
Sorry about this.
No, it's okay. I mean, it's fine.
Okay, so it's 2 o'clock, and I know people will want to hear Angela's talk and not want to hear me. So, and I know some people will be joining. Just to say that this video is being recorded, and everyone will have permission to record it, and then we'll host this in our university and in our centre's website as well. So first of all, welcome, and I know some people will be joining in the next few minutes. So I just want to give an introduction to Angela. So I just want to say that Dr. Angela Hasiosis is Professor of Intellectual Disability in the Division of Psychiatry at University of Central London. She's also the Psychiatric Lead at the London Borough of Camden Learning Disability Services with a clinical caseload. Angela focuses on randomized controlled trials in adults with intellectual and developmental disabilities. Could I just ask everybody to mute when we get a chance, just to mute? Okay, so thank you. Studies range from interventions for challenging behaviour, the weight loss, the alcohol misuse, funded by the National Institute for Health Research Programmes. Angela's service, the Camden Learning Disability Service, won the 2020 Royal College of Psychiatric Award for Best Team in Intellectual Disability. So well done, Angela, and team. Angela was also a recipient of the National Association for Dual Diagnosis Stephen Rees Award for Research, which is an international award. Professor Angela Hasiosis is currently the lead for the NIHR £2.3 million programme called Personalised Treatment Packages for Adults with Learning Disability who display aggression in community settings, a UK-wide study that will in a few months' time involve the Northern Health and Social Care Trust and the Southeastern Health and Social Care Trust. So this talk today that Angela is giving on undertaking a rapid realist review and managing aggression in adults with learning disability is the first stage of this large UK-wide study. I'm just going to give you some of the results on how it was undertaken. I welcome Professor Angela Hasiosis to University of Ulster, who is our visiting professor. And I also welcome Angela, if we were doing this outside of COVID, we welcome you to Northern Ireland, Angela.
Thank you so much.
You're welcome. Angela's going to give her talk now, and then when she's finished, it's going to be followed by questions and answers. So I just ask you all now to turn off your mics and enjoy the talk. And if you have any questions, save them to the end. So we've had a little bit of technical difficulties where Angela's not the co-host, and I apologize. So Angela will just nudge me, and then I'll move the PowerPoint along. So Angela, over to you.
Thank you so much, Lawrence. And really, I'm very pleased to be giving this talk and sharing with you our lessons from doing this work. I will be working with some other colleagues from the university on Realist reviews as well. So this is something that we have to report these days. So my research is funded by the NIHR, and I express only my views, which are not those necessarily of the NIHR, and I have no other conflicts of interest. Next slide, Lawrence. So in terms of the structure of the session, I'm going to talk a little bit about the program grant. I will introduce you to the Realist methodology, what we've done in terms of searching and screening, the summary of our records, some issues around quality appraisal and analysis. And obviously, as Lawrence has mentioned already, there will be some time for discussion. I should like to say that Lawrence has arranged for about 2 hours. We're not going to be using 2 hours, so definitely there will be time for us to have a discussion. And actually, I would be very interested in hearing your opinions. Now, can I just check? I know that Lawrence, you're doing quite a lot of things, but perhaps if I have an eye on the chat, just in case of you know, people putting some stuff there, that would be I think that would be appropriate.
Angela, can I just stop? Somebody has their mic on. The children in the background. If they could turn it off. Somebody could turn off their microphone. Sorry, Angela. Professor Angela. Somebody has their microphone off.
I think, yeah, Lawrence, I think it's William Delaney and Damien McAleer. Yeah. Damien McAleer's off now, yeah.
Thank you, William. Thank you, William. Sorry, thank you if you could just keep your microphones off until Angela has finished her talk, and then we can have some questions. Thank you. Go ahead, Angela.
All right, no problem. Okay, shall we go to the next slide then, Lawrence? Thank you. So this is a program grant which is funded by the National Institute for Health Research. And there is an overarching aim, which is that we want to develop, and we are kind of in the process of that, and test in a randomized controlled trial a personalized treatment package for aggressive, challenging behavior. So we're quite specific in that respect for adults with intellectual disability. Now, just a little bit of background. I'm not saying something that you don't know already, but aggressive, challenging behavior is common, persists over time, and it has significant impacts on the quality of life for the person with intellectual disability and lived experience of that, as well as their families and paid carers. Now, it's a complex condition with varying etiologies, and I hope that we will see this in the process of the talk today. And it is this particular issue that kind of spearheaded, I suppose, the application and will or motivation to develop this personalized multimodal approach to treatment. In terms of setting, this is a sort of almost the whole of the UK. So we've got 3 countries, England, Scotland, and Northern Ireland participating. Next one, Lawrence. So, well, I suppose the question there is for all of you. And actually, you know, you may have this question as to why we chose to carry out a Realist review. What is it that we didn't have already or didn't know already? So then I wonder if we can go to the next slide. So I would like actually to just have a few minutes, and please do put some things in the chat or mute yourselves and speak up if you would like. In terms of how do you think the interventions for aggressive, challenging behavior work? Okay, so Jill has said that identifying, so Jill Titterington, identifying context and alter, sorry, let me just see, this with positive reinforcement. So I suppose that Jill, you're making reference here to a sort of behavioral approach. Medication, for example, whether it's optimizing or stopping or starting, because obviously medication can be used for some people. So already there is that kind of this element of who should be receiving it. And Emma says that they can be very effective if adapted to the needs of the individual and personalized. And someone else, actually Paula, says de-escalation, change in environments. Anita has mentioned the last thing. So that's actually correct. So we all know that, I mean, from what I've seen, we have some ideas as to how these interventions may work. But I would like now to share what the literature is telling us and how the knowledge that you put forward, where it's coming from and how specific is it. So, and assessing functions, absolutely, yes, again, kind of following a more behavioral approach. So that is kind of one way of thinking and one way of approaching or intervening in managing the aggressive challenging behavior. So Lauren, shall we go on to the next slide? Okay, so let's keep these things that we've just mentioned in our minds. And I will now tell you a little bit about this first work stream and what we know from the literature. So first of all, the Rapid Realist Review was one of the work streams that is part of this program ground. So there was there was a first phase. We're sort of almost completing that now, which included the Rapid Realist Review. We also looked at the database where we collect routine clinical data, which is based on a database used by some of the mental health trusts in England. And also we did a 3-country qualitative study. I'm not going to present those findings today, but just to stay with the Rapid Realist Review. So we're interested in complex interventions. We're interested in complex causal pathways. You saw, my first question as to why we chose this particular methodology. And also the Realist Review could provide evidence for the process evaluation gaps, particularly those that are around the intervention implementation. And certainly from my point of view, having carried out a few studies so far, I can see how the implementation can really be a stumbling block in terms of the delivery of an intervention as intended. So we hope that the Rapid Realist Review, and I want to say that the Rapid really is more about how much time one has in order to devote to this particular methodology, we thought was really an important methodology to embrace for understanding this particular problem. So shall we go to the next slide? Okay, talking about complexity, because you may remember that I mentioned something about aggressive challenging behavior being very complex. Now, this is actually what is called the general aggression model. I'm not suggesting that this is something that we all believe in or even think that it's relevant to everybody with an intellectual disability. But this is a kind of model that at least shows the level of complexity in terms of a person presenting or displaying aggressive, challenging behavior. And this cuts across a number of different populations, from people without intellectual disabilities to people with particular mental health conditions to people with intellectual disabilities with or without other conditions. And it encompasses the biology, the environment. You've all mentioned those things already in terms of how you thought things work, something about people's personalities, which has to do with the relationships that we all develop within our families and with our social networks. And then you can go from internal to external states, and then it's about displaying a particular behavior which is driven by thoughts and by emotions and all sorts of other processes that all coalesce to reach that particular point. So I think that, just by looking at this, and I would like to propose that this is a model that we keep in mind, although I accept that it might need either some modification or additions to take into consideration the various elements that are more relevant to people with an intellectual disability. I have to say, though, just as a kind of little tangent here, that we have done some research with my colleagues here in London around biological modifiers, and that's really about potentially genetic processes or deficits that might give rise or be associated with aggressive, challenging behavior. And the point is that if we're not able, obviously, to deal with those biological modifiers, because of course they are at the genetic level, then we have to still deal with the problem in the same way as we would, even if we didn't know that there was a particular biological deficit that underpins the display of the behavior. So that should not really stop us from trying to think about how we might be managing a problem which also has quite a lot of, so not just the nature, but also the nurture, the kind of social and emotional and psychological kind of components that would lead to the display of the behavior. Okay, shall we go to the next slide? So the next thing is about, and this is something actually that we really, those of us who are involved in the process of rapid or realist reviews, we have to really convince our colleagues or change even our way of thinking around the need for a realist review. And I thought that this table, which actually I have reproduced, it's not my table, it's it kind of shows you the sort of differences that we find between these two approaches. So the systematic reviews will have a very specific question, and we will have to make sure that our inclusion-exclusion criteria will be will speak to the particular question. But for the realist reviews, it's actually evidence that we collect from a number of different angles and using a number of different lenses to actually build a program theory. And actually program here means intervention, but it's kind of, using this particular kind of realist terminology here. Sometimes reviews exclude low quality studies, although I can say that having done a Cochrane review myself, which has had 3 updates, the last one sort of being under, we're conducting it at the moment, and it should be completed by the end of the month. But we did not exclude low quality studies because we couldn't find any others. So basically it would have been a review without any studies had we excluded them. So when we go back to 2001, really the quality of the studies was nothing like what we actually have at the moment. So we had 5, for instance, and we've got 15 at this point. So definitely we can see it sort of upward trajectory in terms of the work that researchers have been doing in developing interventions for challenging behavior in the broad sense. This is actually different from the realist methodology, where we would include any gray literature, any papers, opinion pieces, anything that we think might be helping us to put together this program theory, what underpins the impact that we see from an intervention. Now, tend longer to complete, I'm not quite sure, because I can tell you that the Cochrane review and the realist review happening at the same time, I think I almost had a nervous breakdown. So actually they are both very resource intensive, even if they're rapid, especially because of the iterations and refining that they require. So, and they actually need quite a lot of kind of skilled work and so on and so forth. And we'll talk about some of this a bit later. So next slide, please. So if we take the point of view of, well, we've got the systematic reviews, then why do we need the realist ones? I'm just going to mention a couple of papers that have presented evidence for interventions for challenging behavior. And as you see, I'm personally focusing on aggressive challenging behavior, but actually this is not necessarily what the literature is telling us. So the literature is talking about a challenging behavior, and we suspect that the majority of those studies will, the population, if we were to go through and look at them very carefully, we would find that the population in their majority will display some degree of aggressive challenging behavior. But of course, I also accept that these behaviors never happen on their own, but happen with other behaviors that can also be considered as challenging, such as self-injury, for instance, or hyperactivity, and so on and so forth. So this particular meta-analysis, and actually this is one of the papers that's been also, we looked at in great detail at the NICE guideline 11, which is about the management of challenging behavior. So it includes a number of studies that, as you can see there, are across the spectrum. So biopsychosocial, so it starts with, includes pharmacological studies, psychotherapeutic studies, as well as other contextual interventions, which are basically about changes in environment and so on, maybe some training. And these interventions can be used alone in combination or in combination. And I have to say that, of course, many times, I mean, unless something is actually defined, what the title is, a comparison, study of, say, medication X versus medication Y or no medication, then I think that we should kind of take it as given that the number of participants in such studies will be taking medication. Not all of them, but at least 2/3 of the participants. So actually these interventions are almost multimodal, just, from the outset. So yes, there is evidence, because obviously these were case reviews, a case series, some of them kind of clinical trials, not necessarily randomized control trials. But also, there is the evidence, but there was no evidence for superiority of one of the treatment approaches or of combination time. So so if you had, say, medication and psychotherapy, now that's a bit strange, because some randomized control trials actually have shown, and those are in children, we haven't got one yet in adults, but in children, it looks like if you give medication and also do some sort of psychological or psychosocial intervention, probably you have better outcomes. But we are not seeing, that many of those types of studies in our population. The next one, Lawrence. Now, this one is more recent, as you can see. So this is very specific. It's about non-pharmacological interventions for challenging behavior. So we go from this wide context of any intervention to non-pharmacological ones. Although, of course, the issue here is how many of the population were on medication, but that aside. So they, our colleagues who did this work, they found a moderate overall effect of the non-pharmacological intervention. So they think that they work. And they also think that the effect appears to be long-lasting. Obviously, these are studies. So, we may go for, say, 6 months, 9 months, 12 months, possibly a bit longer. But within that context, they found some studies with longer term follow-up. And they also become a bit more specific here, because they specifically mentioned that combining mindfulness and some behavioral techniques seems to be more effective than having other interventions. So at least that gives us some direction, I suppose, in terms of what we think might be more would work. And also it's when we think about what we should be delivering again in clinical care, that might be a way forward in our service development. So that's kind of the first sort of seed of something a bit more specific. Next one, Lawrence. Now, we all know about training. Every intervention includes training, and some of it actually is targets rather, or is directed towards the care staff. And these are the kind of workers who perhaps are not as skilled, may have some vocational training, but they don't know very much. And they are at the forefront, they are at the coalface of helping and supporting a person with intellectual disability who presents with challenging behavior. Now, this is an interesting meta-analysis because, first of all, very clearly talks about the aggressive challenging behavior. So they did say that the majority of the the participants in the papers had a degree of aggressive challenging behavior. So that's a good point. And they looked at two things: whether the training effectiveness of direct care staff, so when we train the staff, will it reduce the incidence of aggressive challenging behavior? And is there going to be a change in the people with intellectual disabilities in terms of the kind of behaviors that they show? So these were the kind of questions they started from. Next slide, please. So what did they find? So what are they telling us is that actually in terms of staff behavior, the goal, in terms of, say, the objectives that we put forward, that we want to improve skills, knowledge, attitudes, and so on, as well as the content, did not have any effect did not change the effect of the training program. Really, you had different kinds of programs, and they all had, by and large, the same impact. Intervention characteristics. Now, how many hours? What was the intervention? How long did it take? Were people, not providing it in the same way? What kind of techniques we used? Because actually, I recall when we submitted our report from the positive behavior support training clinical trial, there was some discussion as to what training techniques did we use. But of course, I mean, we did use a number of different techniques, but of course, this meta-analysis tells us that it really perhaps doesn't matter so much. But there is one thing that potentially changes things around, and this is the high percentage of male caring staff. So if you've got a group of paid carers, for example, where potentially you've got a third or maybe half male to female ratio, you may have a better impact in terms of how the training is being perceived, or rather than if there were only female. So that's kind of something, I suppose, that potentially might have ramifications for the organizations that provide support to people with intellectual disabilities. And I'm not sure how strong this signal is to actually say you've got to really have a drive where you've got enough male carers in your staff complement. So it's an interesting point that. However, the overall effect for staff training programs on the behavior was non-significant. So that's an interesting issue in itself. So the things that they couldn't actually answer was whether staff can change the client behavior. Probably not. They think that looking at the different topologies of aggression might be important. So are you having more, for example, display of verbal aggression versus physical aggression, or say aggressive behavior towards, I don't know, the environment, throwing things around and so on. So I think there is, can I just take the questions sort of afterwards? We'll come back to the, to those points. The training may require actually both individual mentoring and on-the-job coaching. So clearly there is an element here to suggest that we need a lot more resources than we put into the training in general. And I can, having said that, I can give you my personal experience, but nevertheless. So there may be some team and organizational characteristics that play a role. And it's interesting that up to 2018, these studies did not present client perspectives. Now, this is again an interesting point, because having produced some papers about the positive behavior support clinical trial, we put the, we published the client perspectives actually separately from the main trial paper, which is a quantitative paper. So in some respects, potentially us as researchers, we muddle the waters in terms of, how we talk about our research and how much kind of, completion of records we have. Next one, Lawrence. So you can see from these kind of examples that I've given you that we've got complexity and we've got different findings and conclusions depending on the study inclusion, for instance, the kind of questions we ask within systematic reviews, and the studies that are included and how we look at them. So back in the 80s, they thought, okay, we need really an alternative methodological approach, which is kind of more specific to social sciences and actually takes into consideration of more complex systems that, yes, if you've got, active medication versus placebo, a clinical trial is fine, and you can pull them together and you can have your, your meta-analysis and your effect sizes. But if you actually have complex interventions like the psychosocial intervention, it becomes more difficult to do that. So these are kind of some of the seminal papers. So before we knew about Posson and Tilly, we had Chen and Rossi and kind of other researchers that, in fact, it's quite interesting. I will admit that I only knew of the Aspen Institute in the United States when Prince Harry was supposed to become a patron or, a member. But apparently this approach kind of came out from a roundtable, a scientific roundtable at the Aspen Institute. So that was quite an interesting nugget for me in terms of how, the kind of history of that work. Anyway, so they said that for any intervention, there could be a program or intervention theory that can be described that explains how the planners expect the intervention to reach its objectives. And they had in their minds a kind of logic model. If I do X, then I expect this, and then something else will happen. And this was very much about the implementation. I put together this training program and I will deliver it in that way, and these will be the people who take part, and that's how it will go. And to start with, they had two schools of this kind of approach. One was the theory of change, and we're all kind of becoming now, after Susan Mickey being in the social media all the time because of the pandemic, so the theory of change, and the realist evaluation. So these are slightly and different, but also overlapping kind of schools of thought, because you find that when you develop an intervention, you kind of use the theory of change, but potentially you have been guided to an extent by a realist evaluation. So next slide. Can I just say, I understand that Lawrence has also arranged for some of you at least to have some training with Justin Jagosz, who is the supremo of realist reviews, etc. So you will hear a lot more kind of, and you can ask kind of more questions about the history, etc. to him. So in terms of just bringing up some of the terminology, these are some of the things that potentially some of you will be aware of, like the context, the mechanism, the outcomes. So the context is where an intervention or a program kind of takes place. The mechanism is what leads to outcomes. You know, an outcome is what happens. What's the final consequence of, you know, those mechanisms? And there can be a couple of mechanisms in the sort of pathway. And what we look to develop is a CMO configuration. So for every program, we have some idea about the context, the mechanism, and I'll give you some examples of this from the work that we've been doing as part of the program grant. Sometimes people talk about the program theory, and actually in more recent papers, that's what we have. So that is what explains an intervention and how it works. But to start with, there was, you know, the terminology was middle range theory, which is a kind of abstract or abstracted kind of way that led from, you know, this is what we are doing. So CBT, which leads, for example, to the person being less depressed. And there could be all sorts of different things from how it's delivered, whether there is, you know, the therapist is knowledgeable, develops a good relationship, the person actually wants to come forward to receive CBT, and so on and so forth. So you can kind of have different elements there, sort of scaffolding, I suppose, the theoretical pathway that leads you from the intervention to its conclusion in delivering what you intended to. Next one. I'm sure that there will be perhaps some of you who agree, disagree, or have a kind of slightly different understanding, but I'd be very happy to hear all of that a bit later. So next one, Lawrence. Right, so so this is about the you know, how the kind of plan works. That you know, you start with your research question, you have the design, formulate the middle range theory or program theory. You do field studies, perhaps, especially if there's going to be some evaluation as well. You collect data, you refine all the time, and you synthesize, and you sort of come to the end to say, well, this is what we found, and that's what, you know, that's how we think things should take place. Next one. This is, actually, these are not my words, but I thought that kind of mention, or rather summarize, I suppose, what I am saying in, or articulate these points kind of clearly, that the realist evaluation, what it can do is to help the researcher to find out in which specific conditions the intervention works or not, although you start from the point of view that it does, and how, and then you refine the findings in a process of, you know, specification. So you try to test and say, well, you know, maybe this is what we need to be doing, or maybe that theory works, that theory perhaps doesn't. And then that leads to an accumulation of insights that help decision makers to assess whether an intervention that proves successful in one setting may be so in another setting. And how, and this is quite interesting because these days we are all very keen on having share examples of good practice. Now, you know, based on this, can I actually say that something that happened in, I don't know, Birmingham, for example, will happen, or in Belfast, or in another part of Northern Ireland, will be something that we can do in London? And if we could we take that wholesale, or what is it that we need to change? And how many different stakeholders we need to be consulted in order to actually make the changes that we will consider necessary, and will we actually be interested, you know, if the process takes on a very long time. So it's one thing to kind of have these ideas, but then it's another to say, well, how do we adapt and how do we plant one program that was developed in one area somewhere else, and actually that will become very obvious in one an example I've got a bit later on. Okay, next one. So you may be aware of the Ramesses Project. Again, Justin is one of the people who is related to this project. It's NIHR funded, and it kind of shows you a little bit about the kind of what's the realist assumption, how you focus the questions, and then the how you develop the program theory. So you know, just as an example of how the process might work. Next one. So in terms of actually, you know, if we were to break down the stages of a realist review, and what we did is that we needed to define the review scope. So what was the question, as we've seen before, the purpose, we articulated the theories, we search for and appraise the literature, we extract and synthesize the findings, and then we draw some conclusions and make recommendations. And you may remember this kind of diagram that I presented a few slides back. Next one. Now, you also need by your side a local reference group, which needs to have some terms of reference and a membership. And in our program grant, which is called PETAL, by the way, as you might have seen, we had 7 professionals who included occupational therapy and nursing. We had 2 commissioners who were sort of sharing the meetings, and 3 family carers and 1 representative of people with intellectual disabilities and lived experience of aggressive challenging behavior. And then we also had, and you need to have, an expert advisory group or panel, and we had 5 co-applicants, Lawrence being one of them, and myself and the research assistant who was helping us with putting this together. And of course, you know, different researchers may do other things, and you can go as widely as you wish. You can have also an external panel on top of the expert advisory panel, and you can also consult with a wider scientific as well as a kind of clinical and expert by experience community. It's kind of interesting that you know, there isn't, in a sense, I suppose there is always a minimum, but you can expand as much as is possible as well. And so as long as, I suppose, certain kind of basics have been applied. Next one, please. So when we're conducting these reviews and developing the middle range theories and so on, sometimes we can be too abstract. For example, especially if little is known about an intervention or the population on which it's implemented. So you have to make lots of inferences that then potentially goes completely beyond, you know, what is available to base assumptions on. So the program theories could be potentially inserted between the middle range theories and the CMOs. I've seen this, I have to say, it's kind of a point that personally, I didn't think that there is huge amount of clarity in the literature at the moment. And I also think that, you know, a number of papers that I've looked at might have looked, you know, use things either interchangeably or kind of other things that potentially their role is not quite how they are presented, but there is a little bit of, I think, lack of clarity around the connection between the middle range theories and program theories for me at this point is that the program theories are kind of the newer version, I suppose, of the middle range theories. And the mechanisms, it's something to bear in mind. And I know that Lawrence tells me this kind of every time we've got a meeting, that we've got to think about individual, group, organizational, so systems level and societal levels as well, because obviously people live in societies and in communities and so on. And sometimes, say in a public health intervention and so on, some of those things might be really important. If you live, for example, talking about aggressive challenging behavior, if you live in a neighborhood that actually has high levels of, I don't know, gang violence, for example, maybe some things are normalized, and then, you know, we have to think about, you know, how then an intervention might work at that level if, you know, the people who you would target have certain views around the display of aggression, where on occasion, for instance, maybe kind of bravado, or it could be a you know, something that you bear as an honor. So you know, these are the kind of things to consider. Next one. So what can go wrong? And actually, this is with an eye, I suppose, of to a publication. And I have to say that we have gone through some of those things. So convincing colleagues and the people that you work with, whether it's the local reference group or experts or whatever, the scientific community, that you need to do, or there is a need for a realist review. So the understanding why the need is one thing, not buying into the methodology is another. We did have some questions as to, but we know, of course, when you look into something in more detail, you know that there is no we know, but nevertheless, you can set the questions too broad. What would be the role of the program theory? I mean, you can make assumptions, and actually, again, I'm going to refer to Justin. We had some input from him, and one of the things that he was very keen on is that we needed to kind of be more intuitive, or to try and dig as deep as possible within you know, an intervention and the context and so on, to see what else might be said about the particular intervention. So some kind of, how should I say, some terms such as, for instance, kind of feelings of shame, or stigmatization, or love for your son or daughter with a learning disability who presents aggression, but also potentially feeling that you are at the receiving end of that aggressive behavior, and so on and so forth, and how all of those things might interplay in order to then lead to an intervention being successful or not. I told you before about the multiple methodologies, because obviously this is kind of mixed methods. You know, you may use quantitative as well as qualitative data. You know, you look at papers that include both approaches, even other things. You know, an opinion piece, for example, or maybe an observational study and so on, or ethnography, etc., etc. So actually, you need to have a very resourceful and skilled team to be helping you. And in fact, we've got someone who has done this work within, actually a colleague who works with people with older people with dementia, and actually finding enough data. And you know, this is the other thing, how far do you take this? I mean, do you stick with your population, or do you actually go beyond that and look at other information that you think might be relevant and provide you with this data? Next one, please. So in terms of the work that we've done in PETAL, we developed the search terms. We presented them actually at the meeting. We had some comments back, and we kind of refined the search, and we looked at 6 databases as well as grey literature. And we actually asked our colleagues to tell us as well if they knew of any particularly we were interested in anything that might have to do with commissioning of interventions or commissioning priorities and so on. Now, I have to say, we didn't have enough feedback there. But again, I guess at the end of the day, it always comes back to you to see how much further you can take things. And the other issue, which speaks to the last point from the previous slide about the population. Now, this is obviously a Realist review, and we decided to look at adults, but also for in the literature for children, if it was relevant, and concentrate so on aggressive challenging behavior or violent behavior. And because people with intellectual disabilities have a number of different comorbidities, including autism, mental health problems, you know, some of them may have dementia, there is huge amount of literature on violence in inpatient settings, for example, and there is also quite a lot of literature on agitation and dementia. Now, of course, I don't claim that dementia and intellectual disabilities are the same, but there could be some elements of interventions that happen in or are being used in those populations that may be relevant to us. And for whatever reason, we haven't actually adapted them or even considered them. And it's quite interesting that in one of the interventions that we've included, there is only one study, for instance, that actually used that or adapted that intervention for an inpatient unit. And we know how much inpatient units actually can be subject to aggression and violence and kind of restrictive practices and so on. Next one, please. So this is roughly how we went. And in fact, I was looking at some, putting together this, these slides today. And I was looking at the beginning of when we started, and we had like 41 papers to start with. And now we've got 59. So you can see, and this is like a lot of iterations. You may have heard that sometimes people talk about, I mean, we knew that there was obviously some research, with particularly in intellectual disabilities, I have to say, all the research was about challenging behavior. You really have to comb the papers in great detail to see if aggressive or aggression is mentioned in any way, but probably not, because certainly I know that in my papers, I have talked about challenging behavior. I haven't really said how many people perhaps had particular or how many incidents of aggression. So, you know, I cannot blame anyone else. This is really quite interesting. The research in other populations that we've used is actually much more focused, because in children, for instance, they talk about oppositional disorders, or violent behavior in inpatient settings, for instance, violent behavior. They don't shy away from this, but we are talking about challenging behavior. And I will put it to you that this is, I don't know that it's doing our patients and our research, I suppose, many favors. That aside, anyway, we ended up with 59 records. And sometimes in the Realist kind of review sort of domain, people talk about Pearl publications, which are the publications, for instance, say, Lawrence or myself are involved in NIHR funded projects. And when we finish a project, we present this report. The report has everything to do about the project. This is a Pearl publication because it's got everything. It has the process evaluation and whatever. Or it could be that my seminal paper, say, from a particular project, might be the Pearl paper because it leads to identifying all the other papers that are linked to this study. So you can start with that, and then you can sort of build on this, you know, on this work, and you can find all the kind of relevant papers, and also sometimes you can identify. So for instance, Paul Wilner from, I think from Wales, has done a lot of work on anger management, and he did the kind of randomized control trial of lay therapists and anger management, CBT, CBT informed anger management. So he presented, but before he did the 2013 trial, he had several years of other trials, one of which actually I had included in the Cochrane review. So we kind of knew already that there was also some backstory to the 2013 trial. So these are the kind of additional papers, the kind of, you know, additional work that you can then relate or link to particular publications that may lead you to sort of understand a bit better about mechanisms and other contexts, etc. Okay, next one. These are just to show you the kind of studies that we've identified, the kind of conditions. As you can see, of course, the majority of the papers were on intellectual disabilities, but we did actually take quite a bit from sort of other work as well. And all of these studies, you know, of course, had their own kind of particular points. Some studies, as you can see, were sort of included young people as well as adults, and so on. So next one. And these are the kinds of therapies. So CBT, of course, is heavily features. There is a lot on mindfulness, and particularly in people with intellectual disabilities, with some researchers in the United States sort of being the kind of people who have done most of this work. Positive behavior support, I'm sure we kind of recognize some of those interventions. And I want to mention their safe words, which is the one for inpatients, which is about how you bring about a reduction in violence in inpatient settings. And it has a website, and it's a program that's being rolled out in a number of different services, and a variety of kind of different a number of other things that kind of include sort of modalities of different interventions, and they are presented in particular ways. Next one. So overall, there are 6 qualitative studies that we've included. The majority, as you can see, it's interesting, quantitative, and there are 5 that have used mixed methods. Next one. So the quality appraisal, I think this we haven't completed yet, but these are the tools that we are using at the moment, and kind of some of them obviously are sort of standard methodologies, and we are looking to see which ones obviously are contributed to theory building, and we've got this massive document with all of the information and which papers, etc., sort of at the moment. So next one, Lawrence. I will show you some of the theories that we've come up with, and we obviously have consulted with the expert panel as well as the local reference group, and in fact we are going to be sending them out. The local reference group will be receiving our kind of working document, as it were, so that we can get their opinions before we sort of finalize what we have found. And we are kind of pre-synthesis kind of phase at the moment. Okay, next one, Lawrence. Right, so what we have at the moment in terms of how we have categorized our program theories is that some of them are direct interventions. However, all of them require some degree of facilitation, which overlaps to an extent with the relationships that are being built between different stakeholders, say those who receive the intervention and those who deliver it, and also how teams may work between themselves. And again, there is quite an interesting, actually nice little kind of expert from excerpt that kind of illustrates that, that I've got a bit later. And then how we embed the facilitators at a systems level, which is where most of the change of behavior sort of techniques and thinking might be coming in and would be quite important in terms of when, thinking about interventions and buying in. So next one. These are the different kind of categories within each of the each of the theories. So in fact, just to say as a point of methodology, I suppose, that you start with lots of theories and then you try to kind of summarize, although I think, for instance, if you take this second point on under direct intervention, we've got sensory stimulation, meaningful activities. Now, one of the, we had a comment to say that possibly this one could not be combined, that the sensory stimulation is one particular kind of set of approaches, and then the meaningful activities is quite another. So we're kind of looking to see how this can be disaggregated in a way that makes sense. Also, it's quite interesting that some interventions are kind of more relevant to people with mild to moderate intellectual disabilities and others to people with more severe intellectual disabilities. So, or even, the kind of things that we might learn from people, say, with dementia, for example, again, if we were to take anything away from those studies, they would also be potentially sort of more specific to subpopulation groups, and we have to consider that. So we wouldn't suggest that, potentially we work along CBT lines with someone, or even DBT lines with someone who has potentially a severe intellectual disability, and maybe there we need more behavioral activation, for example, or more behavioral approaches like a functional analysis, where we try to understand the behavior from a kind of a very behavioral perspective. Okay, next one. So here I'm just gonna give you some examples of some of those theories. So starting from the direct intervention, if we just go to the next slide, Lauren. So the ones with the bold are the ones I'm gonna talk about, basically, that's what it means. So say about emotional recognition, regulation, and skill development. Now that is quite an important part of the literature, whether it's in children or in adults. And it's not just in intellectual disabilities, but also in a number of other people with mental illness or personality disorders, for example, or in children with oppositional or disruptive behavior. So we have couched those terms, and again, that's kind of something that Justin says, that you can put them as, or display them as if-then sort of statements. So you can see here, we thought that if an individual with conditions such as intellectual disability, where they have mild to moderate degree of that, presents with difficulties in emotional regulation, they could be taught to do different things as part of the intervention. So those would be, those would be the kind of techniques potentially that are part of the intervention. And then you would expect that that could reduce the display of aggressive behavior. That's our final outcome. But actually the mechanism here is that the person learns to better identify emotions, or be helped to identify the emotions in a kind of environment that's very much, for example, conducive to support a person with an intellectual disability to do that. And there, you know, there was quite a bit of discussion around this. What happens if actually that environment, which then goes to what happens within teams, for instance, or how embedded some such culture is within an organization, and you can do that. What if you've got staff who actually say, oh, I can't do this because I'm afraid that I will be at the receiving end of an aggressive outburst. So, you know, there could be some issues there. And the next one. Another way of looking at this would be that in care homes where acquiescing or not causing trouble is expected. So this is the kind of context. Say young people with or adults with mild intellectual disabilities may feel ashamed or afraid in expressing anger, for example. So then they can hide their difficulties. So if you try to work with them, they may actually not want. So this is how an intervention doesn't work. Why someone doesn't engage. So this is a kind of what you might say an opposing theory as to how something might not work. Next one, Lawrence. So this is about building family care skills and self-efficacy. This is quite an, you know, an important element. So then if the families are trained to deliver interventions, and actually sometimes you have to do that in the person's home where people live, and you know, many will be in their family homes, it could increase their knowledge of aggressive challenging behavior. So that would be the context that they are in their home, but also increase their compassion. So we kind of add a potential sort of additional element there, which could be, in fact, a mechanism, which then, I don't know if you agree, I suppose, with us that it could decrease their self-efficacy, maybe because their attitudes change towards the display of aggression, or if it's part of mindfulness, for instance, they've got the skills that because they reduce their stress, they feel more able to respond to such behavior. And they could sustain the behavior change if they change their care practices, if the home is such that can take those kinds of changes. So here, again, it would be important to identify what sort of mechanism we might, or techniques, I suppose, we might use to help this behavior change. Next one. So in terms of facilitators, for example, next one. So trained therapists could tailor the intervention, etc. So that would be, say, on a systems level in terms of being embedded, for instance, in a community team or in a care home. And these can help to achieve a better fit between the therapist and the patient because they address their individual experiences, their complex needs, abilities, and so on. And you can see there the issues around the engagement and treatment satisfaction, which I think we have consider that as a mechanism which then can reduce the display, which is our final outcome. Next one. Next one. So in terms of improving communication, if family members can take care of themselves by using, for example, mindful techniques. So I think this is mechanism one. Or understand the triggers for behavior, that's two. Another mechanism potentially, and respond to incidents of aggression with empathy and acceptance, that's three. Or you could argue that potentially those are the kind of most important, the empathy and the acceptance, then it could potentially lead to this outcome that we want, which is about reducing the carer's own stress, but also decreasing the aggressive challenging behavior. So again, I suppose the outcome there could be more care related as opposed to necessarily the aggressive challenging behavior. Next one, Lawrence. So this is another one about improving communication. This is about the paid carers who are trained in the delivery of an intervention. So understand the reasons, de-escalate where necessary, or reduce conflict. And that could build trusting relationship with the service users, because they're able to create this culture of compassion where they can accept vulnerability, assuming that we think of the display of aggression as such. They might be better able to anticipate expressions of aggression, for example, and then respond appropriately. So we might have kind of two different outcomes there. Next one. And just a couple more, I think that would be the last ones in terms of our CMOs, for instance. Okay, Lawrence, next one. So if the paid caregivers facilitate intervention delivery, this is about then the system, this is the implementation elements. The time should be allocated for them to learn and to practice new skills. And it can lead to a culture of feeling supported by their managers and that they're being valued. And that then can increase confidence and competence in applying and the new skills, and then ensure that there are changes in behavior. So next one. This has been a major issue in terms of the literature that we have found. There have been a couple of papers which are qualitative papers about how families think about paid cares and professionals. And I can tell you that this is, nobody comes out in a kind of good light out of those papers. They're a bit generic, I would say. And they're sort of all about the way that services kind of consider the input of family carers, but we thought that they need to reflect on how to foster common values and treatment goals, which we think is one mechanism. And this consideration that there is love there, that they start from a point of view of actually wanting to be with the person with intellectual disability if they were helped to deal with things in a different way, I think. And sometimes they find that we don't quite hear that. And then that means that if they're listened and valued, they may be more prepared to work with us, because sometimes actually not being able to, even if we've got great ideas, if we can't actually get the families to to adopt those ideas, then we end nowhere. And we know how difficult the family environment can be, because of course, you've got your home in order to relax, not to kind of have to be, doing therapy all the time. Next one. So I said kind of time for a break, but I think probably, we can go ahead. There are not that many more slides after this. So I don't know, Lawrence, what do you think?
People, do you want to just quickly in the chat, if a yes or a no for a break? And just get a sense, and it would be a 5-minute break if people wanted to. That's your computer. Anybody want to go a yes or a no?
Okay, I think no. Okay, fine. All right, then shall we then just go on?
Okay, happy to go on. Yep. Thank you.
So next one, Lawrence. So what are the next steps? So we're still, we've got probably about a month's worth of things that we need to do in order to finally kind of bring it all together. We managed to do 5 case studies of professionals and family and paid care dyads. It hasn't quite worked like this, I'll tell you in a minute. And we are using some of this work for the petal treatment package. Next one. Okay, I think COVID has been a real problem. We managed to interview 4 healthcare professionals that were all psychologists including inpatient forensic and community clinical experience, so kind of quite a broad range in that sense. With specific sort of experience on things like DBT or DBT informed, that's dialectical behavioral therapy, informed practice, and CBT as well. One service manager, one family carer. And I'm just gonna present to you here the kind of a couple of insights that I hope sort of, first of all, in my view, they link with some of the things that we've discussed, but also kind of show the reality of what happens within services. So we had some topic guides where we're trying to see what happens when things are being implemented in, in interventions, etc. What works, what doesn't work, what the problems are. And it's quite interesting to see how those colleagues kind of spoke about their experience. So next one, Lawrence. So you can see here, so the first bit is about, because an environment that is calming, that has greenery, that has colors on the walls, whereas there's no paint flaking off, echo is reduced, it's not overstimulating all the time. Now, this person was actually talking about the redecoration, or they needed to convince the service managers to give them a therapy room where they would have people coming in to do their DBT. And it's interesting because this, almost word by word, in the Safe Words manual, they talk about how soul destroying is to go into an inpatient setting, for example, and have the color on the wall peeling off or being dirty. And these are the sort of things that also CQC is looking for when they make a visit to a clinical setting to say whether it's good or not and it needs improvements. So it's actually quite interesting how that, according to that person, sort of really helped to almost bring the kind of optimism and the fact that it was, people felt valued by having this room, that they were being heard. So this is kind of how you embed something in practice, in a system, that the managers agree to give you that time and that, space. The next one, this is all the same person, okay? So that anybody around that person, any staff member or adult who had a relationship with a young person knew about the treatment that we're doing, knew about the progress that we're making, knew about the skills that we're practicing, and was encouraged to actually support them with that. So this is kind of a systems approach, hearing everybody, kind of pulling everybody together to to help this person to create this culture of we accept, we understand, we will remind, so all the things that we know are important in terms of getting someone to practice and embed and learn, even in a direct intervention, you have to remind someone, you've got to do these things, because if they're anxious and upset, they will go back to what they used to do, which is obviously not going to help. The next one is he felt frightened. He felt ashamed by some of the work that we were doing. And he had this sort of explosion and problematic behavior. Now, this is interesting because this explosion problematic behavior is not, as it were, just out of the blue. We don't know. This therapist, this psychologist kind of has some ideas, has some sort of kind of mechanism in his mind, as it were, that might lead this person. The fact that you do some therapeutic work is not always devoid of potential kind of unanticipated consequences, perhaps, or maybe anticipated, that you can, because you feel so upset about something, you kind of lash out. So that was the kind of message in that. And then something around not supported by the wider service, that makes it even harder to do systemic interventions, because then you just get resentful staff that are less able to reflect. So this is about, who does what? Are you more valued if you do the intervention and not if you're not, especially if we talked about direct care, are some people or staff better than others, or in, different tiers, and so on and so forth. So all of these things, some of these are very obvious, like the room, and some are kind of very, very intuitive, that you have to really, and they wouldn't be necessarily reported in the papers either. I mean, this is the thing, because there are lots of things that in fact not necessarily being mentioned. Okay, final slide, which is, now we had some discussion previously about the, you know, how interventions work, and you had some ideas. Now, having kind of heard all of this, do you think that there is, would you change anything from what you've said? And in fact, I'm just I'll open it now to any questions or any thoughts. And I know that there are some, you know, things in the chat as well.
Yeah, there's a couple of the participants, I don't want to put people on in the participants, they were saying for the first time that they felt family interventions had been underdeveloped with where they work, and they hadn't thought about undertaking mindfulness with the family care. They do it with the person with learning disability, but they were saying maybe it's a good idea to do it with families as well. So I don't know if Barbara or Geraldine want to speak or whatever, or maybe just chat in the chat room. Don't like putting people on the spot.
It's not about putting, I mean, I'm interested because, you know, I want to hear
Lawrence. I think, I mean, you know, it's certainly something I recognise that we probably don't do as well as we could have, if at all. So I suppose, you know, I did appreciate Barbara coming in there as well, thinking, yes, that's something that we, you know, we need to maybe think about doing more. I don't think families do feel empowered to manage, you know, often challenging behaviour or difficult circumstances. But sometimes I do think it begins in childhood, and you know, it's about managing maybe difficult behaviours in childhood, or during children's transition, as opposed to just adult services alone. So it's about the trajectory of, you know, the person with a learning disability, and maybe I suppose it's just really skilling up. You know, I suppose mindfulness and self-care and all of that's more important now more than ever during the current climate. But when you've somebody, particularly during COVID and lockdown and all the rest, that would have been very, very difficult when day services and other services were stood down. So I think that's certainly something we could bring back to trusts.
Yeah, and I would agree totally with it. I think, as Geraldine says, it really does have to start in children's, and the early intervention work is extremely important, so it is. But yeah, I like the idea of the mindfulness, and I have done different types of mindfulness with the person that I'm working with, but I've never actually thought of spreading that out to include the whole family. Throughout my time as well, and more so working when I was in children's, we had offered rap sessions to parents, which they found very beneficial. That's sort of gone a bit by the wayside since COVID, but again, it would be something that, you know, it would be really, really good to get started again.
Thank you.
I think Jill was asking if we have an overarching program theory. I don't think that we kind of, not in as many words, I suppose, or fully fledged, but I actually am coming to think about these as coping and addressing or managing. So because it's, and the managing will be direct, it would be you know, through family work, de-escalation, kind of a number of different techniques that take into consideration lots of kind of mechanisms, etc. But in terms, and coping is all of this about the self-care, about the nurturing and supportive environments, the kind of culture of seeing this as a problem that we can, you know, we can help or think differently about, having some values, or, you know, so working together, you know, so I guess that's kind of where we are at this point.
Any other questions you want to ask, Angela? Either you can unmute or you can write it in the chat room. Just to say to Geraldine and Teresa, you know, the Southeastern Trust and the Northern Trust have agreed to be involved in this project. So, you know, we will be coming to you shortly through Matt McMurray and through Richard Whitehouse. You know, to look for a couple of participants to engage in the feasibility, and then obviously as we roll it out to the bigger study. So you will have the opportunity to engage. So look out for the emails that I'll be sending soon. So that'll be happening in the next few months, probably this summer or whatever.
I think one of the things that has surprised me to an extent is that beyond positive behavior support and some specific papers that talk about particular interventions, when we actually ask people what they get, they don't seem to be fully aware of what it is that they provide. And actually this person that I showed you excerpts from the interview, he did say very clearly that his practice was, that he was not a therapist per se, a DBT therapist, but his practice was informed. He was using kind of different things that thought were important. And I guess this is another point about personalization, that in mental health, we can't actually, it's not like, for instance, we would do a genetic screening and say this medication is good for you. What does personalization mean? Now, he actually said that this was personalization, the way that he was doing things. And definitely I could see the dedication. He talked about doing a like 70-mile journey or something to see a patient. But the thing is, also, do we use the techniques that we've got in the best way? Do we have even the right names for those things? What do we say to people in terms of what we offer? So I wonder as well whether there are some kind of such sort of soft things that perhaps need a little bit more. I don't know, we have to think about them, I suppose, is my view at the moment. I can see there is something else in the chat. Someone says, will care homes in Southeast have an opportunity to be involved? I would say they would be involved, because obviously some of the participants who have obviously a history of aggressive challenging behavior will be living in care homes. So certainly, and I have to tell you, this is a cluster randomized trial. So I can't say which cluster, obviously we don't know at this point, each trust will be. So then all the homes around the particular kind of catchment area will be in either the intervention or the treatment as usual arm. So you would be involved in a sense, but if you're not in the intervention, probably you wouldn't be involved in that sense, that nothing would happen beyond what you do usually. Okay, Felicity, thank you so much for your attention. Then there was something about, were there any somatic experiencing interventions for managing difficult behavior in the review? Okay, so definitely we've got something about sensory stuff. I don't know if that's what Paula means by somatic experiencing interventions, but we didn't find anything. If you mean like theater type or kind of dance, kind of some of those interventions being used for psychosis, for example, we didn't have any such interventions here, but we did have some on sensory management for aggression. And actually that was also in dementia. So things like foot baths and stuff like that, kind of aromatherapy, those kinds of things, they were being provided. And then, something about Anita's question on male staff influences. Okay, so basically there's this one paper, one meta-analysis. I don't know if we did the same now, we would find the same, results. But there was something in that meta-analysis or the papers that have included that suggested that if you've got a higher ratio of male to female staff, not that everyone has to be male, but if you've got enough male staff, then somehow the training seems to have a better impact in terms of how people respond to it and if you know, they take up the techniques or whatever it is that they're you know, they use it for. So it was, I suppose, what you might call what we sensitivity analysis. Overall, didn't matter, but it was very important if you looked at male to female. And also, you know, bear in mind that at least in the UK, and I'm sure in other countries, most care staff are actually female. So, you know, I don't know how you can possibly, but if that's kind of such a big impact, I mean, there may be something there as almost a policy point.
Can I just add, Angela? We did a couple of papers in Northern Ireland research. We got a Judith Lawson Trust, a small amount of money, a few years ago, and we looked at mental health in women with learning disabilities, and we were very much aware that in mainstream psychiatry, in England, particularly the Department of Health, they had a number of gender-sensitive policies around women and men with mental health problems, nothing to do with learning disability. But in learning disabilities, we don't seem to be very gender sensitive. And I'm very conscious of a PhD student we have called Dr. Paddy McNally, and he's looking at trauma-informed care, developing a trauma-informed care framework for residential and supported living schemes in Northern Ireland. So I'm just very conscious of that finding around male staff and the impact it has around, I think, what is it diminishing aggressive behaviour? I don't know if that has any say in relation to, I'm not sure what it's really indicating, but I don't think learning disabilities has many documents around a gender sensitive culture for mental health and learning disabilities. And I think with some of the work we've done, and particularly some of the work Paddy's going to be publishing in the next couple of years around trauma-informed care, that would be really interesting.
I need to also say the evidence of behavior interventions and reduction of the need for restraints or physical techniques. Okay, interesting, because whilst we've been doing this work, we've become aware of another group in Manchester, Metropolitan University, Joy Duxbury, for anyone who might know the name. So she's doing actually a Realist review of interventions for restrictive practices. That was not our aim, that was not our scope, just to, you know, take you back to the kind of remit of what we were doing. So we are interested in aggressive behavior and what happens to actually bring down aggression, but they are looking at the use of restrictive interventions overall, and they're following a little bit of a similar methodology in terms of what they're looking at, in terms of how wide they've cast their nets, etc. And actually, I think the problem they've got is that I mean, it's not a problem because you can kind of, I suppose, find different ways of explaining things. But they said that in some communication we had with Joy, when we were thinking, is there overlap and so on, that actually they could not identify specific studies in intellectual disabilities. Probably there are some, but they're not going to be randomized. I mean, we had the majority of the studies being randomized controlled trials, not just in intellectual disabilities, but in other fields as well, kind of as the field generally. But probably for restrictive interventions, there may be more cohort, case summary, so case series and so on and so forth, or there may be kind of, you know, editorials or things like that. So it'll be interesting to see what they find once they finish this. So I couldn't, you know, really comment on that. And the evidence for behavior interventions, I think, well, they're being used, so I, you know, there is overall evidence, but in a randomized kind of controlled way, I don't know, because there haven't been that many such trials. So even in our Cochrane review, actually, it's only the positive behavior support studies that I've done, and one by Peter McGill in, can you believe that, in Tizard, all of these years. So other studies are either in children, or they're for CBT or DBT or different kind of, like what we would call single interventions. But we definitely take the view that aggressive challenging behavior is so complex that actually to just do one thing is not enough to take into account every single problem, that an individual presents with. And then frequently through behavior, people communicate, well, they cannot communicate in another way. Medical cause, yes, I assume you talk about physical health here. Problem is there are no specific ID pathways respectively in Northern Ireland addressing this, and GPs have limited understanding. I agree. I mean, it could be anything. And actually, as part of the intervention that we are putting together, we've got something that it is about maintaining well-being and sort of looking into health, etc. So it's not necessarily that people don't do that, but if it's kind of part of something very specific and manualized and you have to do in a particular, context, then potentially could be taken up and be more effective than if it were, just something, especially the pandemic actually has thrown awry all the kind of, all the stuff that we've done about the annual health checks, because GPs are not actually seeing anyone at the moment. I mean, well, they're starting to see people. Let's not, I'm not blaming the GPs, but I think that our population would have more difficulty in actually taking part in those annual health checks, etc. We have to remind everybody that they need to be doing those things and they need to go in and they need to be, so some things have actually gone backwards because of problems as well that we're having at the minute.
Any other questions you want to ask or put in the chat? I suppose I would say that there's lots of stuff coming from this study, and obviously, as these are published, I'll be able to send them around all the networks in Northern Ireland and keep you up to date. Like you're saying, we're into year 2 now, Angela, is it?
Sorry?
We're into year 2 of this
2,
study,
yes. Yeah.
So there's another 3 years of the study, like a feasibility, and then a full trial where the Southeastern Trust and the Northern Trust will be involved in. So it's great, that we have representation in Northern Ireland and to be included. So thank you very much, Angela, for that. Any other there's another question from Paula. Okay.
Yes, Paula has asked a very kind of sciencey question. We are not particularly mechanistic. We suspect that some of it obviously will be. Okay, so the thing about the intervention is that we are not necessarily, we're developing a new intervention, but that doesn't mean that we're developing completely new intervention. So some of the things that we consider as including will have their own mechanisms kind of behind them. And within this sort of context of assisting, I mean, some of those things like behavior activation, etc., has a particular theory. We kind of accept it. But we think that by using some change of behavior and upfront kind of thinking and putting things together that we know. So we've seen that mindfulness kind of works, or at least there's, even if it's to reduce, say, stress, for instance, which might be then leading to aggressive behavior, etc. So if that person feels shamed or whatever, you could say, well, if the shame leads to the aggressive behavior, because that's how awful they feel, well, maybe after a session, I don't know, you need to have something to help this person to kind of, reduce this, sense of being aroused or whatever. So we think that, all of those things are obviously evidence-based and they have a mechanism, but we wouldn't go as, as far as saying that we are kind of saying, it will be kind of, frontal lobes of decision-making or whatever. Obviously, some of it will be, because first of all, the person has to agree to work with us. They have to to do certain things potentially. They have to make some decisions indeed. So yes, there will be some, but we are not kind of mechanistic at that level, I will say.
Okay. Any other questions or comments? I know some people are having to leave and sort of out now for other meetings.
Should we stop here, Lawrence, do you think?
Yeah, I'm happy enough if everybody
I don't
else.
know. I mean, you know, I'm just saying.
Yeah, any other burning questions you want to ask Angela? Okay, so look, Angela, just to say thank you. I mean, it's a great summary of an amazing project that's going to take place, and it is fantastic that we're going to be part of it here in Northern Ireland. I think the questions show that people are very, very interested in understanding how aggressive interventions can be personalized, and looking at the context of these interventions. Thank you. I have a number of questions, but I mean, I'll pick these up later on with you, you know, but
we can discuss them at other times, Lawrence.
Everybody's, I think, as you can see, everybody's thanking you, Angela, for your time and effort. Like I'm saying, Angela's our visiting professor. She was with us this morning, and she's going to be back virtually with Ulster University tomorrow morning and on Friday as well. So Angela, thank you for your time for this project. And you can see everybody's thanking you and really interesting presentation. So I'm going to stop sharing. And thank you, Angela, very much.
Thank you very much for your attention, everybody, and also for your, your questions, etc. And we will be thinking some of those things as well, as the feedback that we've got from today in kind of finalizing our review. So yeah, well, have a good rest of the day. Thank you so much as well, Lawrence, for the invitation, and you will hear kind of other stuff from Justin as well.
Angela, thank you very, very much. Thank you,
and I'll see some of you tomorrow as well. So
right.
No, not tomorrow, Friday. Sorry. Yeah.
Right, Friday. Thank you, everybody. Thank you. Bye-bye. Bye-bye.
Bye.
Lawrence, you can hit stop recording now.